Good morning. My name is Aurelian Geru. I'm a surgical trainee in London and the co-course director of Intense International Teaching for ENT Surgeons. It gives me an immense pleasure and honor to welcome you to our first webinar in the series. First of all, a huge thank you to ENT UK and the Global Health Committee for making it possible, and in particular to Miss Sarah Timms, Miss Emma Stapleton, and Mr. Nick Ainan-Lewis for their support. Dr. Gan Edin Naran-Solomon is the other co-course director. Do you want to say a few words, Gan?
Yeah, sure. I prepared some, and yeah, it's I cannot actually procrastinate say something because it's an really honor to be part of this webinar. Thanks to all speakers and panelists who accepted and participated in this webinar, as well as all attendees. I'm 100% hopeful that today's presentation and discussion will give us a huge benefit. And also, our president of the Mongolian ENT Society is absent by some reason. So on behalf of Mongolian ENT Society, I need to say something. So also it's a pleasure to introduce our first international webinar cooperated and affiliated with ENT UK Global Health Committee. And we are here for not only aiming to concentrate, gather experiences, but also expanding our international network to improve Mongolian ENT service. Also, I would like to thank that ENT UK considered our issue and also announced that our great endeavor reached this point. I hope that our operation will last long. And also, I can't forget to imply my most sincere gratitude to my dear friend Aurelian. So thank you, all of you.
Thanks, Gan. I'll quickly give you an overview of the course and how today will work, and then we will start the talks. So the Intense course has 6 topics selected by the Mongolian ENT Society, which will be delivered through 6 webinars. This is the first one, entitled Tinnitus. In part 1, which is the first 20 minutes to half hour of the webinar, we will hear about the patient journey and the gold standard of care in the UK as presented by our panelists. We will then have a 20-minute discussion forum with UK experts, where we want to hear where you have identified differences in practice between UK and Mongolia, and what we can learn from each other, what practices might be transferable from Mongolia to the UK or from UK to Mongolia, and also identify any needs you may have in providing the best care for your patients, which might then form the targets of support by ENT UK. And part 3, which will happen after the session, there is a reflective and evaluation form to complete on Google Forms, and I will put up the QR code for that at the end of the session. Completion of the form will then entitle participants to certificates of attendance. If the majority of webinars are attended in the series, there will also be a course completion certificate. Thank you all for joining us, all participants to the webinar. Please write your questions in the Zoom chat, and these will form the basis of the discussion forum in part 2. So now it gives me great pleasure to introduce Miss Emma Stapleton, consultant ENT surgeon at the Manchester Royal Infirmary, and 2 specialist leads in audiology, Danny Kearney and Jenny Griffin, who will take us through the patient journey of tinnitus in the UK. Thank you very much.
Thanks very much, Aurelian, and thank you, Gan, and thank you to everyone that's logged on. I know that it's afternoon time for you guys. It's the first thing in the morning for us here in the UK. And it's a real pleasure to be here for the first in our series of 6 webinars, which we've agreed to do in the first instance for you guys. And you guys have chosen the topics for these webinars. So hopefully we'll be able to share some of what we do and generate some really useful discussion afterwards. As Aurelian's mentioned, what we'll do after this one is we'll gear up for the next coming one and send you a link to be able to sign up for the next one, which is on nasal obstruction next week. So what you guys have asked for is something on tinnitus, which is a really, really enormous topic. And I think you've also asked for vestibular schwannoma. Now, these are both really, really big themes. There are entire books written on each topic. So I am going to touch on vestibular schwannoma, which is one of the differential diagnoses of tinnitus. But I'm going to really focus my short talk today on a whistle-stop tour of taking you guys through tinnitus as a clinical entity. And Danny and Jenny will then tell us a bit more about how to manage it and how to manage these patients. The presentation of diagnosis of tinnitus, what we know about tinnitus, it comes from a Latin word meaning ringing, and it just refers to the perception of a sound which isn't there externally. And it's not a disease or an illness. Tinnitus isn't an entity in its own right. It's a symptom that's generated within the auditory symptom. It can be in one ear, it can be in the other ear, it can be in the center of the head, or it can be really difficult for the patient to pinpoint where it's coming from. Oop. In terms of its incidence, it's really common. Tinnitus is very, very common. And if we look at the literature and what's published about tinnitus, we know that it affects 10 to 15% of all adults at some time, and 3 to 10% of all children at any time in their life. We know that the incidence increases over the age of 55 and in patients who've got other conditions. It's a significant problem in 1 to 2%. Interestingly, if you look at studies that have focused solely on children, the prevalence of tinnitus in children is really high, and it varies from 12% to 36% in children with normal hearing and 66% in children with a hearing loss. So this is a really, really common condition. There was a really big study of hearing in England done a couple of years ago, and this told us that the incidence of tinnitus in adults is about 10%, so it's very, very common. 2% found it moderately annoying, 1.6% found it severely annoying, and 0.5% or 1 in 200 people had tinnitus that severely affected their ability to lead a normal life. So hopefully we've got the impression that this is something very, very common, but that can also really affect people's lives significantly. If we think about risk factors for tinnitus, it's really important to keep these in mind when we're taking our history for from our patient that's presented with tinnitus. And just keep in mind all the things that could be causing their tinnitus, because often we can identify an otological or a neurological problem, but many times there's not anything that's easy to identify. So it's really important to include trauma, ototoxic medications, and a patient's overall health in your history taking, and especially their psychological state and their stress levels, which we know can seriously feed into tinnitus experiences for patients. So essentially, tinnitus can be broadly separated into 2 categories: subjective tinnitus, which is heard only by the patient, and an objective tinnitus, which is attributable to a real sound. And we can try and divide these up when we meet our patient in the clinic, and we can examine their ears, find out whether there is some ear pathology causing their tinnitus, or it's really important as well to use a stethoscope, listen for a carotid bruit, feel for any neck lumps, and just see whether you can hear the patient's tinnitus yourself. All patients with tinnitus should get a hearing test. This you guys will recognize as normal hearing in the left ear and a dead ear on the right. This patient will probably have terrible tinnitus, and it's unlikely that they will present just with tinnitus. And I think this leads us into the fact that tinnitus doesn't often come alone. It often comes with something else, with a hearing loss, with some dizziness, with stress levels. But it's really important to do a hearing test to see what the status of the hearing is. Another really important thing, which is very, very accessible to us, we can book MRI scans at the drop of a hat. This comes from an American Academy guideline whereby patients who have unilateral tinnitus get magnetic resonance imaging. And I've put 2 side-by-side images here. They both show a T1 weighted MRI scan with gadolinium contrast, and the image on the left has got a small intracanalicular vestibular schwannoma, and this looks very small, but actually it's a benign tumour of the wrappings of the nerve cells, which could give patients really awful tinnitus that really interferes with their quality of life. And on the right, we've got a much bigger vestibular schwannoma. This would be much more likely to have caused balance problems, symptoms from compression of the brainstem and the cerebellar peduncles. And when you send a patient with unilateral tinnitus for an MRI scan, there's about a 97 to 98% chance it'll come back normal. But the reason we do it is because we're looking for lesions in the inner ear. Now, as I mentioned earlier, vestibular schwannoma is a really big topic. And if you want to have another webinar on skull-based conditions and vestibular schwannomas, I think it will easily fill a whole nother session. So some things to think about with tinnitus: it can originate anywhere along the auditory pathway, anywhere at all. And as I've mentioned, when we do imaging, we often don't find anything at all. So it's really difficult to pinpoint exactly where it's coming from. One of the most popular theories, and there are a number of theories for tinnitus, is that tinnitus arises from uncontrolled neural feedback loops. So when there's decreased hearing in the cochlea, the brain makes its own sounds and creates a feedback loop, which can be exacerbated by stress. So in terms of the central nervous system as a tinnitus generator, the theory is that through the loss of cochlear input to neurons in the central auditory system, this can result in abnormal neural activity. And this has been backed up by some really nice neuroimaging studies which are in the literature. And this gives the patients their perception of tinnitus. But actually, it's the patient's own neural feedback loops that lead to the abnormal auditory perception of tinnitus and their experience of stress. Although we don't currently have a cure for tinnitus, the fact that we have an increasing idea of the pathophysiology of tinnitus means that there are avenues for potential future therapies. And actually, there are some big companies, especially in the USA, that are pouring a lot of money into research in this area, because the tinnitus industry is worth a lot of money, a lot of work days. And the goal is to produce a tinnitus therapy that can act on the neurotransmitters and neuromodulators to create a pharmacological target for tinnitus therapy. Yet to come. Surgical management of tinnitus, I'm going to touch on very briefly. If your patient has an identifiable ear disease that you want to operate on, it's not guaranteed to cure the tinnitus. So you should absolutely operate on the cholesteatoma or the vestibular schwannoma, but it is not guaranteed to cure the tinnitus. In fact, it can make it worse. The literature tells us that most patients with a vestibular schwannoma do have troublesome tinnitus at the time of presentation, but once the tumour is removed, so you've essentially taken out their inner ear with a drill, about 50% will find that their tinnitus is better and 50% will find it to be unchanged. And in the short term, their tinnitus is often actually a little bit worse. Pulsatile tinnitus is actually a very different entity. This is a subgroup of tinnitus where you often can find out where it's coming from in terms of vasculature and abnormal vasculature, such as a paraganglioma, which, as you guys will know, is a benign tumour of blood vessels, which can give really profound pulsatile tinnitus. There's an increasing body of evidence about abnormal vasculature near the inner ear, and there are published case reports about people cauterizing or tying off diverticularly of a sigmoid sinus or AV malformations and curing patients' tinnitus. This is quite big surgery. If you've got a bit of a noise in your ear, this is a big risk to take, which may not work. And there's also an increasing number of centres which are looking at jugular bulb abnormalities. So if somebody has a high jugular bulb and pulsatile tinnitus, they can investigate whether this is the cause of the tinnitus by occluding it with a balloon to see whether that temporarily stops the tinnitus. And this is not something for ENT surgeons. This is generally done by interventional radiologists in a number of very special centres in the UK. Cochlear implants for tinnitus is quite a big theme. Obviously, the cochlear implant market is for patients with profound sensorineural hearing loss, but actually more than 80% of cochlear implant candidates have tinnitus at the time of presentation. And this is because they've got a profound sensorineural hearing loss. And there are some researchers around the world who are looking at the effects of cochlear implants on their tinnitus. And they found that cochlear implantation improves or eliminates tinnitus in the vast majority of patients, and some report it to be worse post-operatively. But in general, once the implant is switched on and they're getting some access to sound, this essentially masks the tinnitus or makes it better. There is 4% who develop tinnitus after surgery who didn't have it preoperatively. And I really don't think this is surprising. I do a lot of cochlear implant surgery, and I still think it's quite amazing that we can introduce a foreign body to someone's inner ear and they don't get terrible symptoms of tinnitus and imbalance. So it's unsurprising that a small proportion do. Meniere's disease is a really common cause of tinnitus, certainly in my practice, and the tinnitus can persist despite efforts at treating the hearing loss and the imbalance. The literature tells us that surgical intervention for Meniere's disease can provide relief from the tinnitus in a majority of patients. And the emerging literature on intratympanic therapies, so intratympanic steroids, intratympanic gentamicin, do seem to result in a higher percentage of patients describing relief from their tinnitus. So there's definitely more to come on that in the near future. Okay, so I said I was going to give you a whistle-stop tour. So to keep us on track, just a few more things about tinnitus, which I think are important for you guys to know before I hand over to the guys who really know what they're talking about. Firstly, I think it's important to remember that tinnitus remains a clinical and scientific enigma. And I'm really open with my patients about this. I tell them, we can try and make your tinnitus better or easier to cope with, but there isn't a cure for it. We don't always know what's causing it. So there's lots of research to come in the future with regard to tinnitus, lots and lots of future research regarding imaging and potential therapies on the horizon. I think it's really important for us to keep in mind as clinicians that tinnitus can really severely affect people's quality of life. And there is a documented increased risk of suicide in patients who have tinnitus and pre-existing psychiatric disorders. So this is not something to take lightly. It's a very serious condition. It's really important to remember that surgical management of ear pathology doesn't cure the tinnitus. So when we're operating on a cholesteatoma or a perforated eardrum or anything at all, really, it's really important to counsel the patient to manage their expectations, that we can't guarantee that operating on the pathology will improve their tinnitus. And finally, there aren't yet any effective drug treatments for tinnitus, but I think there are some on the horizon. Finally, if we look at the Cochrane database, I'm sure you guys know about this, it's supposed to be the highest level of evidence, and they collate lots of systematic reviews and meta-analyses. And looking through there at the studies which have been done on therapies for tinnitus, there really is no evidence for the vast majority of them other than cognitive behavioral therapy and tinnitus retraining therapy. Now, tinnitus retraining therapy, I'm going to hand over to my expert colleagues because we're very lucky in the UK in that as an ENT surgeon, we assess and investigate our patients, but actually the majority of tinnitus management is done by, there it is, by our expert audiologists who are much better than us at this. And on that note, I'm going to hand over. So if I stop sharing.
Hello. Yes. Sorry about the delay there. Can you all see the slides? Is it visible to?
I can't see them.
Can't see them yet.
Just try that again.
Can't see me.
Is that visible now?
Yeah, we can see them now. Thank you.
Yeah.
Lovely. Okay. Yes. So thank you, Emma. And my name's Danny. So I'm going to take you through the management of tinnitus, which is the next section here. There we go. So our audiology practice in the sort of management of tinnitus is guided by NICE guidance that we implement into our local sort of protocols for tinnitus. And also there was a large multidisciplinary European guideline for tinnitus that was released in 2019 as well. So these are very good reference points for tinnitus practice, and guidance on management and the evidence behind that. So I just thought I'd share that with you. In terms of the tinnitus patients we see and how they present, they'll often come to us with their tinnitus, but alongside that, there's anxiety and depression that they may be experiencing, sleep disturbance, which can often have a real effect on them, feelings of hopelessness and helplessness, and difficulties with concentration, and also, as we touched on, the distress associated with hearing loss, and their quality of life in not being able to hear as well as they'd like to. So those are some of the things that we try and address in our sort of tinnitus management, and take a kind of a holistic approach with the patient. So patients will often present to us, and as Emma said, there's no sort of medication or surgical option necessarily for them, and that's often what the patients will want. They'll want a sort of a quick fix. Is there a tablet I can take to try and help with the tinnitus? And I suppose part of what we do is sort of talking to them and letting them know that perhaps that there aren't those sort of options available, but there are lots of other things that they can try. So in terms of management, I'll go through them now, things like support and hearing aids that will help them with CBT and relaxation, and different forms of support there. Just to draw your attention to the British Tinnitus Association as well. So they're an excellent source of information about tinnitus. You can direct your patients towards that information, or look at getting, I suppose, kind of translations of some of the informations that they put together there. They have a number of very good kind of visual aids, and I've tried to share some of those within the slides here. And this sets out, the one I'm sort of presenting there, sets out some of the different management options and things that you can discuss with patients. So it's quite a nice grid there of different therapies, but I'll go through some more of those now. Another sort of step in sort of supporting the patients with their tinnitus is to explain and go through the investigations that they may have had, their hearing test, to discuss the kind of the origin of tinnitus a little bit more with them. Often there isn't an exact location of where the tinnitus is arising from. It can be subjective, it can be objective, forms of tinnitus. So it's very individualized towards the type of tinnitus they're experiencing and their history when they present to us. So part of our time is sort of explaining that and reassuring them, about the results that they've had, and those sorts of things. And yeah, Emma sort of touched on some of the different pathologies that can lead to tinnitus, and mechanisms behind that. But some of it's very, like I say, it's a very kind of individual thing in terms of how people experience it. We often have patients with normal hearing who present to us experiencing tinnitus, and it's explaining to them and giving them management techniques. Often where they've got normal hearing but they're experiencing tinnitus, it may be more sort of related to stressful events that they've been through, and the brain sort of being in a heightened state of awareness and picking up the neural activity, and experiencing that as tinnitus there. This is a diagram that I like to go through with patients in clinic, which gives a bit of an overview of the model of tinnitus. So tinnitus retraining therapy is kind of based on the sort of Jastroboff-Hazel model of tinnitus and how people experience that. In our clinics, we use a slightly kind of modified version of that, which I like to think makes it a bit more accessible to patients and perhaps can be explained in fewer appointments. And this model is kind of a kind of simplified version of perhaps the model that they'll go through within tinnitus retraining therapy. It cites the kind of the source of the sound as the kind of the inner ear, and the pathways between the inner ear and the hearing parts of the brain. With all different sounds, there's a process of filtering in certain sounds and filtering out certain sounds. You may have things like ticking clocks or electrical appliances, fridges, and those sorts of things. And usually in day-to-day life, the brain is quite able to sort of filter those out, and we don't notice them as much. But other sounds can be very, very noticeable. The sound of our own name. If we've got a neighbor perhaps that's a bit noisy that we don't get on with, then that sound can really kind of resonate with us, and be something that gets filtered in. Again, with all different sounds, we're kind of evaluating them, thinking about the sounds, and judging those sounds. And that's then interwoven with our kind of emotional response to different sounds. So how we feel about those sounds, and obviously if they're negative feelings, then it resonates a bit more with us, and the brain kind of interacts with it, and it that sort of pattern of activity has a kind of slightly higher status in our thinking. And that then, if it's perceived as a kind of a threat or a warning, is linked with our autonomic nervous system, and our body kind of reacts. The muscles may tense up. We may feel that anxiety, that stress, and concern about the tinnitus. And in feeling that, it can then open up the filters more within our hearing system, as the brain is trying to work out what's going on. Why are we feeling that way? And so the tinnitus can become louder and more prominent. And so, we use this as a tool to try and explain, that cycle of the tinnitus to patients. But it also leads us on very nicely to the different ways of trying to sort of manage the tinnitus and tackle these different parts of the cycle. So in terms of the source of the sound, there are obviously kind of hearing aids, or just kind of background, environmental sound therapy tools that people can use. Now it's kind of apps or smart speakers that people can use to play different background sounds. But I suppose being outdoors more can be very helpful for introducing some background noise, so that people aren't in very quiet environments and the tinnitus is sort of very prominent for them. In terms of the evaluation of the tinnitus and the way that we think about it, having the investigations, understanding more about it, trying to think about it in a bit more of a neutral way, is very helpful in sort of managing it and understanding it more. And then having ways of managing the impact of the stress and anxiety it may cause. So relaxation exercises, mindfulness techniques that I'll come on to, and those types of things. So this is another diagram, again slightly more simplified from the other one. This is from one of the hearing aid companies, Oticon, and again this can sort of take you through the sort of cycle of distress that's associated with tinnitus and help you to explain it to patients, and then you can also then have the different management techniques with that as well there. So yes, in terms of the NICE guideline, it does talk about tinnitus support and agreeing a management plan with patients to try and help them on their journey of kind of managing the tinnitus. Discussing the results of each assessment and its impact on the management plan is important, and that reassurance of those tests that they may have had done, and that information is very useful. So yes, and that goes with the information. And ear protection advice, ear care advice can be very useful to help prevent a further sort of worsening of the tinnitus. In terms of sound therapy, where hearing aids are required, it's very important to offer hearing aids to patients. I suppose where, as Emma said, where the hearing's more severe to profound, then cochlear implants can also be an option, and different devices as well. But we have a lot good feedback about, our hearing aid users that experience tinnitus, and the hearing aids really helping with the tinnitus, helping with their hearing and making the tinnitus sort of less noticeable. Where hearing is in at normal levels, you can have kind of devices like hearing aids that are just tinnitus sound generators. So that's also an option, or you can have a combination of both, where they're a hearing aid and they've got a combination device built into them as well. So we do have a few different options on that side of things. This is something we use to kind of help explain the impact of sort of sound therapy. So the tinnitus is kind of the spike within the sort of diagram there, and the lower line is kind of the ambient noise in quite a quiet room. But if you're able to kind of increase that ambient noise through hearing aids or sound therapy in the background, then the tinnitus seems much less. There's a decreased contrast between the tinnitus and the background noise there. So again, these are quite good sort of visual aids just to talk through with patients and show them, to help explain some of the therapies that you're offering them. These are some of the different apps that are available. So they're free to download. They have lots of different sounds within them. The important thing is for the patients to find something quite neutral that they can have on in the background, and that they can play. Perhaps it's in the evening before they go to bed. So they can be very useful. So yes, that's some information there about the hearing devices and the benefits of those. And cognitive behavioral therapy is something that in the evidence, in the literature, there's more evidence behind the benefits of that. Increasingly, there are online forms of delivering this, and within audiology, that's something the kind of field is working on to produce more. I suppose in previous years, it's perhaps sat more so with psychology. So it's useful to have good connections with colleagues in sort of psychological services, or that you can perhaps refer to depending on the clinic setup there. That's a bit more information about that. So it's really about having ways of controlling the thoughts that are unhelpful or inaccurate about the tinnitus, and developing some skills in that area. So tinnitus groups can be very useful, and we do have a local one in Manchester that we do signpost patients towards. Like I said at the beginning, sleep management is quite important also. So advising patients on sleep, on their sleep sort of pattern, on good sort of sleep behaviors, can be really useful to help with that aspect of things. So yeah, and the BTA do have some good information about that as well. Some other devices to help at night with sort of sound enrichment there, and then relaxation. So it's good to talk with patients about the different ways in which they may relax, and help their sort of tension and stress, and to discuss some exercises with them that they can practice a few times a day, in order to sort of manage the stress that may come from the tinnitus, and also external stresses that may contribute to the tinnitus as well. And mindfulness, again, increasingly in the literature, is something that is being used and studied to help with tinnitus. And there are now apps that can help with that as well, so patients can kind of do it in their own time. And there you go. So yes, within those slides, hopefully hopefully we can share these, and there's some useful tools within that to share in clinics. But I'll pass you over now to Jenny to talk about the sort of follow-up process there.
Okay, so this third section is follow up to what we've talked about already, and thinking about public health and prevention measures that we might be able to introduce to reduce the incidence of tinnitus as well. So I'm just going to speak briefly about preventable causes of tinnitus, other causes of tinnitus, and public awareness and public health. So preventable causes of tinnitus, this is mainly around excessive noise exposure, which I don't think we've really touched on yet. So what do we mean by excessive noise exposure? So it depends both on the level of the sound, but also on how long we are exposed to the sound for. So that's shown on in the blue box on the screen here. So at 80 decibels, it's safe to be exposed to that level of sound for around 8 hours per day. But as you increase the decibel level by 3 dB, the safe amount of time you can be exposed to the sound for decreases by half. So once you get to 107 decibels, it's only safe to be exposed to that level of sound for 1 minute per day. So a small increase in the sound level has a big impact on the amount of time that you can safely be exposed to that sound for. And just to give an idea of what those kind of decibel levels mean, on the left of the screen, you can see some of the kind of day-to-day things that you might encounter and what level of decibels they might be. So a kind of average conversational level is maybe around 60 decibels. But then if you're listening to music on headphones, that could go up to potentially 110 decibels at maximum level. So it's only safe to listen to that maximum level for less than a minute each day. So different types of noise exposure that we might encounter. So it could be industrial. So in noisy industries like construction, factories, mills, mining, music industry. So in the UK, employers have a legal duty to protect their employees' hearing under the Control of Noise Work Regulations from 2005. So that includes providing hearing protection if needed. If the noise exposure level reaches 80 decibels, so 80 decibels over like an 8-hour period, then employers are legally bound to start taking action. So there is a website, the link's there, which has a little bit more information about the legislation and what's recommended. In terms of noise exposure in industry in Mongolia, I was trying to find out a little bit more about this, and I'm sure you can tell me lots more, but it seems that the mining sector, from what I've read in Mongolia, is quite large. It's the single largest industry, coal, copper and gold mining, accounting for 55% of industrial output. So potentially a lot of people could be exposed to a really high level of industrial noise and could be therefore prone to both hearing loss and tinnitus. In terms of legislation that is applicable in Mongolia, again, you can tell me more, but from what I've found, there isn't specific legislation like there is in the UK around specific noise levels and what employers have to provide. The other main source of excessive noise exposure is recreational, often in terms of music. So that could be people listening to music via headphones or gigs and concerts. So it can be hard to tell when sound is too loud. But if you can't talk to someone who's about 2 meters away without shouting, then it's probably that you're being exposed to dangerously high levels of sound. So the advice if you're listening to music via headphones is to take regular breaks of at least 5 minutes every hour to give your ears a rest. Use a volume limiter on the device if there is one, and don't go above the safe volume limit that appears on your device or phone if you have one. And you can use some noise cancelling headphones so you can listen at a lower volume as well. For gigs and concerts, then earplugs can be a really good idea. So you can get specific kinds that are made for clubbers and musicians that don't muffle the sound completely but make it a bit quieter and safer. So there are lots of different types, different costs available. In a music venue, stay away from the speakers. The closer you are, the greater risk of hearing damage and tinnitus. And it's a good idea, again, to take some regular breaks from the loudest areas to give your ears a rest. So thinking about other causes of tinnitus that we've kind of already spoken about. So just thinking about in terms of access. So if you have ear infections, middle ear disease, and obviously access to treatment for those things is really important to treat those infections or middle ear disease, but also potentially to reduce chances of tinnitus getting worse. In terms of permanent hearing loss, again, access to ENT for diagnosis purposes and access to hearing devices, so hearing aids, cochlear implants, bone-anchored hearing aids is really important, as well as access to support and counselling around the tinnitus. And then other unknown causes, so like Danny mentioned, we see a fair number of people who have normal hearing but still have tinnitus. So again, the access to support and counselling around that is also really important. And general thoughts about kind of public awareness and public health regarding tinnitus. So safe exposure to noise in industrial settings. So obviously employers and employees need to have good awareness about this, and legislation needs to exist and to be followed and enforced in order to make sure work settings are safe for people. Safe exposure to noise in recreational settings. So awareness amongst the public is really important. There was a campaign by the British Tinnitus Association in the UK a little while back called Plug 'em, which was all about using earplugs in kind of gigs or noisy situations. If you don't know you need the ear protection, then it's kind of too late by the time you've been exposed to the sound and developed tinnitus. And then just access to help in terms of ear health, hearing loss and tinnitus support is obviously important too. So I guess that's probably a discussion topic as to what access there is already in the UK and in Mongolia, and if anything needs to change around that. So thank you.
Thank you so much to our three panelists for a fantastic talk and introduction on tinnitus. So now we're going to start the discussion forum part of the webinar. We have one first question from MD Sarul from the National Centre for Maternal and Child Health in Mongolia. And so open question for the panelists. Are all the modules of tinnitus treatment available to use in children? Is there any difference between adult and pediatric treatment? And is there any difference between ages in children and treatments you might employ? Who'd like to field that one?
Yes, yeah, I can answer that one. In terms of the information and the management, I suppose it's kind of the same, but we sort of tailor it, I suppose, more to children in terms of the explanations and reassurance that we provide. I mentioned some of the information on the British Tinnitus Association, and they do have some booklets that are more tailored to children with more pictures and I suppose simplified explanations, more sort of storybook forms of talking about the tinnitus. So yes, we do look at those with some of the more pediatric patients, and also I suppose still going through the process of fitting them with hearing aids and talking to their parents perhaps more around things like ear protection. I suppose that's maybe a consideration in sort of younger people, and something that's useful to start at a younger age with, depending on what sort of noise they might be exposed to. So yeah, there's certainly some resources out there, and it can be more tailored towards children. But it's generally the same. Yeah, it's just sort of tailored towards children.
Thanks, Jeff. Thanks, Danny. There aren't any more questions yet on the chat, so please feel free to post, everyone, and we will get through them. Gan, do you have any questions?
Yes, according to the the information that I just had. I have two questions about that. So the first one is, what is the most prevailing cause of origin of tinnitus in the UK? And also the second question is quite related to psychologists, because it is quite interesting that I just knew that the suffering with the tinnitus patient who is, just mostly cannot deal with her or just his behavior, so can cause of suicide. So what is the main role of psychologists? So also there's some mentioning about the cognitive behavioral, so tests or therapy, something like that is already mentioned. That is the reason I just asked. So.
So two questions there. The first
Yes.
one,
do you want
to comment on the role of psychologists in particular in terms of tinnitus, which you touched on. Yeah, do you want to expand on that question first, Daniel?
Yes. So yeah, I mean, we often see patients perhaps that have some, I suppose, trauma or they may have experienced stressful events, bereavements, PTSD, those types of things, and then sort of the tinnitus is added onto that, and they can be very, very sort of stressed, and managing, I suppose, things like PTSD, and getting some psychological input for that, and our role, I suppose, is kind of helping to identify that, and we use a couple of questionnaires, I suppose, to look into that as part of our assessments, and we can work with the patient's sort of general practitioner to obviously share some of the information we gain within our appointments, to signpost and direct them to mental health services, and obviously then give them support within our appointments. The tinnitus itself can cause a lot of stress and impact on their relationships, affect their sleep, which can then often create a bit of a cycle as well. So yeah, it's helping them with that and giving them the advice we can, but I suppose knowing our limits and signposting them to psychological services, working with their GP and local mental health teams as well.
Yeah, and here we can signpost people to the IAPT services, which is improving access to psychological therapies. So people can self-refer, or we can refer them on for psychological therapies. So that might be cognitive behavioural therapy or more counselling therapies as well.
Which questionnaires do you use for psychological assessment?
The GAD-2 and the other one called the very short screening depression questionnaire. This is 2 questions for each
Brilliant.
one.
And can you comment on the most prevalent cause for tinnitus in the UK? What do you see most of?
In audiology, it tends to be associated with kind of gradual sensory neural hearing loss and a gradual reduction in hearing, and perhaps the patient hasn't been as aware of the hearing loss and hasn't noticed it, and it's when, I suppose, they start to get more of an awareness of it, they start to perhaps experience tinnitus. So yeah, that on the audiology side, that's perhaps what we'll see most of, but it can be very varied. And I suppose that sits quite nicely in terms of the management that we can offer, because we then can talk to them more about hearing aids and, I suppose, communication tactics and those types of things.
I think there's another question there about, have you found correcting hearing loss with hearing aids to improve tinnitus in your patients? So I mean, not everyone who we fit hearing aids for says the tinnitus improves, but I think a large proportion would say there's some improvement when they try hearing aids.
Yeah.
Thank you. Maybe the next one is more for Emma. is it useful to use electrical stimulation to the patient with tinnitus? And what's the difference between electrical stimulation and cochlear implants? Or maybe that's one for Jenny and Danny. I saw.
I'm not sure what they mean by electrostimulation.
Yeah, I have seen some of these devices, that some companies put out, and perhaps it's like an electrical stimulator on their tongue or on another part of their body that they use. And I don't think the evidence base has really found that to be very useful. But yeah,
so that's not really something we use in the UK.
No. And I mean, it's perhaps more in the research stage. There are perhaps more sort of companies out there that are trying those types of devices, but yeah, I don't think there's been a large sort of study done independently that's shown any sort of benefit from those yet.
Gan, do you routinely use those devices in Mongolia, or?
Absolutely not. So I just saw some notes, the results from the research. So what kind of patients can get some benefit from the electrical stimulation, by the way? The questions from the Jenny and Danny also.
Yeah, well, yeah, I mean, like I say, we've not really experienced, and we don't really issue those sorts of devices in terms of like an electrical stimulator. I mean, I'm aware of them from sort of conferences and those sorts of things, but yeah, there's no evidence base behind them. I suppose they need to be quite well regulated if they're providing kind of electrical stimuli in that way, and I suppose the different companies that produce them will perhaps have a different location that they want to put them on to create that stimulation. But yeah, we do not sort of direct patients towards that type of therapy. It's certainly probably an area for more research and work really before it comes into clinical practice.
So my impression of those devices is that they're actually about sensory distraction. So if it's the ones I'm thinking of. So in a way, it does sort of fit in with the sort of the CBT approach of not concentrating too hard on your tinnitus, in that you're actively trying to distract yourself by giving yourself an electric shock on your tongue or whatever. So I think they're interesting for the future, and it may be that there is a certain type of patient that will benefit from them. Someone that actually benefits from being distracted, because that takes their mind off stressing out about the tinnitus. It's just a thought. That was my thought when I first heard about it anyway. But as you say, there's no hard evidence for them.
Fantastic, thank you so much. I want to ask a few questions to Gan now, and we will ask these questions at every discussion forum for the series. So we're running out of time, Gan, but really I want to hear from you what are the key points that have come from today in terms of differences in practice between the UK and Mongolia? And is there anything that particularly catches your eye that you might transfer to your practice? Oh, you're muted, Gan.
First of all, actually what I do more often is the sinus issue. So I'm not familiar with this, but what I did get from this course is actually everything I did just saw was quite new for me, especially the some device-based, some distractions for tinnitus, something like that, and also cognitive behavioral therapy, and also some kind of adaptation issue for tinnitus. That was quite new for me. According to all of that, the point that I would like to transfer to my audiology field in Mongolia is hard to explain, because most of the issue is based on some technical issues, something especially the audiometry. First of all, the patient who's suffering tinnitus, we have to properly to identify, examine the patients, we need to do it right. So after that, also we have to evaluate and also manage how to manage it, and furthermore. So honestly, in Mongolia, the audiology field is kind of what you expect right now. So actually, I can't tell it furthermore. So what I could get is some psychological issues, because the Mongolia's GDP is so low. Also, very limited health knowledge in the peoples in Mongolia. So who is suffering tinnitus is also originated from some middle ear infection that's quite related to the health hygiene, something like that. So mostly Mongolian issue, the tinnitus is caused by infectious causes. So
That's brilliant, Gan.
yeah,
Thanks.
yeah, that's why I just firstly asked about most prevailing the cause for tinnitus in UK. So because it's so it's really different.
And another question in the context of tinnitus and audiology as a specialty, can you think of anything that Mongolia really needs or lacks, which might serve as a target for support from the ENT UK community?
Yeah, that's a really good question. Actually, really good. Yeah. Now we are working on this speech audiometry, so we have to identify and recognize which hearing impairment it is based on some speech audiometry. So we just initiated some project that the co-working with this Seoul National University Hospital from South Korea. So it's going quite well, smoothly actually. So the next thing that we have to more concentrate on is some actually it's balance issues because the tinnitus cannot present by itself. It has to present with something else, with vertigo and also hearing impairment. So we need to identify just the at least some balance issues. So for example, Meniere's diseases can also present with a tinnitus. So we need to identify and isolate them from the disease. So some technical issues, yeah, absolutely.
That's brilliant, Gan. Thank you so much. So I'm now going to put up the slide for the QR code for the reflective form. And if it's easier for you to access, there is also a link in the chat to the reflective form. The form is really essential for you as learners to think about everything we've discussed today. And it's also essential for us as organizers in order to improve the series as we go along, and to decide whether this is worth repeating in terms of the evaluation of the series. So I give you a little bit of time to fill that out. And sorry. And just in the final minute, Emma, I think there's a question for you. Is pulsatile tinnitus just related to vascular abnormality? Is it common for patients with heart problems? If the patient has pulsatile tinnitus, is an MRI test completely required or not?
Yeah, this is actually a great question, and I think it's really important to reflect on the differences between different health systems. We're a very privileged, high-income health system, and I think we over-investigate our patients with tinnitus. They nearly all get an MRI scan, and the ones with pulsatile tinnitus often get a CT scan with contrast as well, and that's to look for vascular abnormalities. And as I mentioned earlier, the vast majority of those scans are normal. So in answer to your question, yes, imaging is done. It's not always that helpful. And often we might find incidental findings through over-investigating and over-imaging our patients. Can patients with cardiac problems present with tinnitus? Yes, absolutely. I've diagnosed a few very hypertensive people who've presented with pulsatile tinnitus.
I think I need to the last statement from Aurelian to the audience with some translation, I think. Өнөөдрийн энэ хурал вебинарт маань оролцож байгаа хүмүүс хамгийн сүүлд гаргасан тэр QR кодыг уншуулад за өнөөдрийн мэдээлэлтэй холбоотой юунуудаа өөртөө олж авсан мэдлэг болон цаашаад нөгөө санал болгох өөрийн санал хүсэлтээ бас тэр хэсгээр илэрхийлж болно. Гол нь энийг яг одоо бүгэлж өгснөөрөө хамгийн гол нь та бүхэн үүнтэй холбоотой энэ сургалтанд хамрагдсан гэсэн гэрчлэгийг бас авах болно гэсэн үг.
Thank you very much, Gan. Thank you, Emma, Jenny, Danny.
Thank you, Jenny, Danny. Thank you.
Yeah, thank you so much. And we hope to see you all on the 13th of July for the next webinar on nasal obstruction. The link will be generated soon and distributed by Gan. If you need to find the link again, Gan, I will give you the link for the reflective form. Remember that the attendance certificates we can only hand out once the form is completed, and you need to give us your email for that. Thank you so much all, and see you next week.
See you next week, guys.
Thank you. Bye.
Bye.